another area, which is a very delicate area, I will try to make it understandable and short. And in this session, I will discuss with you how to select the patients and treat them following solid scientific evidence. It's possible to create a simple, effective, and shortcut algorithm in selecting and treating patients. So here is the general information. The carotid artery stenosis is important because it is responsible for 20% of all strokes, and in the REACH registry, the 1-year absolute stroke risk is over 3% in asymptomatic patients. And the recurrence rate of epicyclic ischemic stroke in severe stenosis increased from 2.7 within the first day to 11.5 within the 14 days after the first symptom. The majority of recently symptomatic patients will gain benefit when carotid interventions are performed within 14 days of symptom onset. So, in carotid stenosis is defined as symptomatic if associated with stroke or transient ischemic attack in the preceding 6 months. Asymptomatic carotid artery disease is defined as no symptoms at all or where symptoms occurred before 6 months ago. This is the definition according to the ECG guideline, the latest ECG guideline. For a net benefit of the procedure, carotid intervention should only be performed in cases if the operator can provide a periprocedural death stroke rate of less than 6% in symptomatic or 3% in asymptomatic patients. This is also a recommendation from the ECG guideline. So the most common non-invasive ways of screening for carotid stenosis is duplex ultrasound. The patient is coming to our clinic with a duplex ultrasound. This is a very shortcut triage chart for you, and it helps a lot also me. And if we have in carotid stenosis over 50% by ultrasound screening, we have to ask ourselves whether the patient is symptomatic or asymptomatic. If the patient is symptomatic, then digital subsection angiography is indicated. And if the patient is asymptomatic, then you should follow the patients annually with ultrasound. And if the degree of the stenosis reaches 70% or more, then this patient is also a candidate for digital subsection angiography. We mean in asymptomatic patients. So we are doing digital subsection angiography, and is the patient symptomatic? Yes. Is the stenosis over 50% according to the NASCAT criteria by angiography, digital subsection angiography? Yes. Then the patient is indicated for carotid artery stenting. And if the patient is asymptomatic, then we need a threshold of over 60% according to the NASCAT criteria to give the patient an indication for carotid artery stenting. I am going now with this case here. This is a 52-year-old female. My default approach in carotid intervention and angiography is the radial approach. And firstly, I do the digital subsection angiography. I mostly do not combine angiography and stenting in the same procedure. I do it separately. So this is an asymptomatic severe right carotid internal stenosis. You see here the severity. And we have a symptomatic severe left carotid internal stenosis on the left. And why I am doing separately the angiography? First, to ascertain the severity of stenosis by angiographic means, whether I am going to intervene or not. The second is to understand the blood supply of the brain, okay? And third, to determine the anatomic arch, because it will also lead my way how to go with the procedure. So this is, you have seen the right carotid internal artery, and here is the left internal carotid artery. You see the loop here, it's a very tortuous loop, and we were able to take an angiography from that side. You see here is a 90% or 90% stenosis also. And you see this is the brain angiography before intervention. And you see that this is the anterior cerebral artery also supplying the right side of the brain through anterior communicant arteries. And this is what happened during angiography. You see the bubble?
Yes. Right system.
Yeah. Mm. This is you should take. You should not do. Okay. I've my guy, my technician, Ismail, was on vacation. Okay. They sent me a new technician. I said to him, "Is the line free of bubble?" She said to me, "Yeah, it's free of bubble." Okay. And then after the angiography, you see, our chance was in this that we had a tight lesion in the internal carotid artery. Okay. Because the bubbles reach the internal carotid artery, and then they convert to the external carotid artery. Okay, the bubbles were too large to go into the internal carotid artery. That was my chance. If you are doing carotid intervention, if you are doing carotid angiography, your team must be prepared. Okay, your team must be experienced how to deal with the patient and how to help you in terms of this. Okay.
And you don't do, of course, you don't use any machine like the assist or anything. So you inject with your with the syringe directly.
No, this was with the machine. Yeah, I just wanted to know the anatomy. Okay?
This is the
arch. This is a big deal.
This is big deal. Yes.
This is a big deal, and the big deal. I wanted to see the arch anatomy because I wanted to know which approach I am going to do in the intervention. So this is a big deal, and we did it with the machine. Okay, and we have to check the line. I asked her, "Is there any bubble?" No, there is no bubble.
But in general, when you go and inject directly, so you use syringe directly and you inject, rather than using the manifold.
I have a manifold. Yeah, I use the manifold. So there is no lesion that can't be treated with carotid artery stenting. The patient is okay, by the way. But there are certain clinical and anatomic features in which carotid artery should be preferred. Here is the list for that. And as I said, I will share with you my presentations.
Mm.
So here is the life case. I have prepared the life case for you. İsmail 2 dakika şey yapsınlar.